Dr. Quiñones, come up and talk to us about Doppler, pearls, and pitfalls.
If you remember, Dr. Little said something very interesting in his talk about looking at this huge sample size across the country. And he talked about how many people started with severe AS and then they were checked by somebody else. Severe became mild. I mean, so clearly, even though echocardiography is still the first arm of evaluation, there are problems. So what I'd like to do today is touch on some of these issues so that hopefully we learn how to prevent them and do a better job. So first thing we want to do is measure the gradient, right? And we all know how we do that. We do a CW Doppler tracing, and we do the 4V square equation, which is a simplification of one in very large equation. And we simplify by basically saying, yeah, that's not important. Oh, this is so small. This is the proximal velocity is only 1 meter, and 1 square is 1, so who cares about that? So we get rid of this, we get rid of that, and we end up with this, which we can quickly change to 4V squared. So that's how we got that equation, okay? All right. Now the question is, what happens if V1 is not 1, but it starts getting higher? One of the questions. The other problem is, if you don't have a discrete stenosis, so if you have basically like a membrane, aortic stenosis acts like a membrane. Mitral stenosis acts like a membrane. If you're looking at TR for pressure, for assessment of PA pressures, you're assuming the TR, the valve acts like a membrane. So it's called discrete stenosis. But if you have a length, a tube, that equation becomes more complicated because factors that you got rid of come back to haunt you, okay? So this is a very nice case that puts out, and this is our own screw up, okay? Not mine, I didn't do it. No, it happened in our lab. This patient had an echo, symptomatic, 90-year-old, she's sick, she's symptomatic, and she has that jet. It was called 5, but that was way over called. But clearly it's 4 meters. Very nice, 4-meter jet, right? And this is from the report. They got a stroke volume of 74, they plug in the equation, and they got a 0.7 valve area with a mean gradient that was greater than 40 in the report. Patient met all the criteria for TAVR, and she was taken to the cath lab for TAVR. These were her pressures. Luckily, our guys still put catheters in and check things out. So this is what she had. Mean gradient of 20, valve area 0.9. This is the tracing that was obtained. And that's it. And this going back now shows you the valve, how it looked anatomically. So this was not critical AS. Yeah, but wait, you had a velocity of 4. What happened here? Okay? Well, look at what this patient has. Very hyperdynamic heart, small heart, and look at how the LV outflow behaves. And look at the acceleration. Normally, you would expect acceleration to occur right here at the level of the valve. It's happening way out here. So what this lady had was a tunnel-like outflow tract. So that throughout a distance, that blood is accelerating, and the 4V square equation then is way oversimplification. And she also had velocities up to 1.5 meters per second. So it exemplifies what I just said, that evaluation of this patient would have been a lot more tricky. And the person who read it basically missed this. See, so this is the type of patient that should have had something else. Should have had an anatomic assessment, CMR, something else, even a cath. I mean, there's nothing wrong sometimes with putting catheters. Sometimes that's the best way to go. The sad part of this story, and goes back to what Paul just said, the TAVR was aborted. The family was called in, and they explained things to them, that the AS was not as severe, and her symptoms were probably diastolic heart failure. They were not happy, so they went to another institution where someone else did their own echo, and they did the same mistake, and she ended up with a TAVR at another place. Guess what happened to her symptoms 6 months later? Nothing, because she had severe diastolic heart failure. Pointing out to exactly what Paul said about, saying no and how sometimes family react to that. Anyway, that's another side of the story. The other problem that we have, of course, is when we have two stenoses next to each other, because the CW picks everything. So this happens clinically once in a while. Here we have somebody that has a subaortic membrane, and also have some AS. So we have two diseases where now the CW is giving you sort of a total velocity across total gradient. This patient needs other type of evaluation. This patient needs probably a good heart cath, okay? And the other most common that we see is hypertrophic cardiomyopathy with SAM and aortic valve stenosis. Sometimes we can see both jets, and sometimes we can work through it, but again, these are situations where the best thing to do, get good anatomic evaluation of the valve, and there's nothing wrong with putting a catheter. Sometimes the TE can help, sometimes the CMR can be very helpful, and there's nothing wrong with going in there and doing a well-done hemodynamic study. So that's lesson 1, okay? Lesson 2 is the more common day-to-day bread and butter situation, where basically you need to be sure that when you are doing your CW, you're parallel to the AS jet. And that's why the insistence in multiple windows. Apical is the one we most commonly do, but right parasternal, suprasternal should be tried in every patient, because lo and behold, you may find that your 5-meter jet happens to be coming from a right parasternal. A nice example here, this patient had a member of AS. That's the best we could do from the apical windows. Bingo, 4.7, beautiful rounded jet from the right parasternal. When looking at ASs, pay a lot of attention to the contour. The more rounded it looks, the more suspicious you should be of severe AS, regardless of the velocity that you see. Likewise, if it's very triangular, you might be, and it has a high velocity, maybe a high flow state. There are other things you have to question and make a more detailed assessment. Nice case of a bad LV, big, bad, and ugly. Look at this 2.2 meter jet, still rounded. Still rounded. Now here is about 3.2. So this is a low flow, low gradient AS, but see how rounded this is? Now note what's going to happen after this PAC. This is the post-PVC, almost 4. So this patient does not need dobutamine. This patient has critical AS, he needs a procedure. Today we probably would think of TAVR. So, but again, notice that even with a low velocity, you still have that rounded contour. So the contour of the AS jet, very helpful on your day-to-day evaluation of these patients. And then you have situations like this, where it smells like AS, and the echo is pretty like, okay, is that the best you can give me? And you try the best and you don't get much, and contrast helps. So contrast turns the lights on, we can see a nice ventricle, hyperdynamic heart, and you get now a full spectrum. So contrast is very helpful. Beware, when you do contrast, try to always stay within the modal velocities, your highest intensity speckles. Don't start going into way out little speckles out here, because that will overestimate. Same thing if you're doing TR velocities with contrast. Always stay in that modal, strongest, where the bulk of your blood cells are reflecting back. But contrast can be very, very helpful. This is a very important study done 100 years ago, but it showed reproducibility between centers, between different observers, and note how tight it was for velocity, okay? Very tight for velocity. As I'll show you in a minute, not so tight for valve area. So when we look at day-to-day serial assessment of AS, our Achilles tendon is not the velocity, because most of the time people can hit that fairly well, is the valve area. And the valve area, because it depends on two factors. One, that measurement of the LVOT diameter that can be all over the place. One day they got 1.8, the other time they got 2.2. I mean, people are careless about how they do this. And the second one, of course, is you also have to place the sample volume in the right place and get a decent LV outflow velocity. Either one of the two can get you in trouble. Whereas the velocity of the jet tends to be fairly reproducible. And this is from the same study. Look at valve areas all over the place, okay? because of the variability in the LVOT diameter. If they went ahead and fixed the diameter in one number, they had a pretty good tight relation. So, lesson for all of us is when we're doing serial assessment, really go back, take a quick look at previous echoes, what numbers they gave for the LVOT diameter. If you're happy with one number, stick with that number. I mean, it's amazing when we look at serial echoes in AS patients, go back, it's been all over the place. One person measured it at 1.9, another one at 2.2. I mean, it's just all over the place. And that creates a lot of problems. And that can be one of the reasons for all these things that we see. What Steve showed you, one center saying severe yes, another center saying, no, it's not severe, it's mild or moderate. So this is really a very important point. Next is functional. It's what we call severe. So if you look at the guidelines, they talk about less than 1. If you look at most of the TAVR trials, they have used 0.7. Why? Because of what I'm going to show you next. This guy has a 0.95 valve area, okay? Mean gradient of 23. Healthy, happy, good EF, playing tennis. Are you going to really do something with this patient? Is this really severe AS? Okay, then he comes back a year later and he's 3.5. Actually, this is also a nice example of relatively fast progression within a few years. But it's a nice example of also showing, here you have triangular appearance, okay, 3.5, 32 millimeters, good EF, good cardiac output, 0.8, and then now he hit 4, and now see how rounded he now gets? All of this would be called severe if we use 1. So this business of using 1 or less has created a lot of confusion, and it's another reason why sometimes people go to one center and they're told you have severe aortic stenosis, and they go to another place and they say, no, you're not severe, okay? So that issue of using 1 as a threshold, to me, was a mistake. I, from day one, was in disagreement with that, and I think it's still a mistake because it's creating a lot of confusion across the country. And all AVS of 1 or less are not created equal. So in summary, pay attention to the contour of the AS velocity. Will always help you, even when the velocities are low. Always search for the highest velocity, multiple angles, multiple places. Use contrast, but beware when you use contrast not to overshoot either. The equation of Bernoulli, you have to keep it in mind. You have to remember that it's a long equation with a lot of factors that sometimes can come back to haunt you if you disregard them, as in our little 90-year-old lady. CW cannot distinguish multiple gradients from multiple sides. And in those situations, you really have to stop and hope and probably get help from other techniques. And there's no problem with doing a hard catheterization. And reproducibility is much better for the gradient and not so hot for valvaria because mostly of issues with the LVOT diameter. So beware of that when you're doing serial studies, which we often do in these patients. Thank you very much.